I'm Alice and this is Eloise. This evening we're going to be showing you how to examine the knee. So firstly you'll want to do your hand sanitizer, introduce yourself and get your patient demographics. So hi, I'm Alice, I'm one of the medical students. If I could take your full name and date of birth please.
Eloise Smelly, 15th of the 11th, 1995.
Thank you. So today I want to do an examination of your knees. That's going to involve me having a look at them, getting you up and having a walk around and doing some movements with your knee. Is that alright?
That's fine.
Lovely. And are you in any pain at all?
No.
Lovely. So first of all, you just get them to stand up at the beginning. Have a look at them from the front, from the side and from the back. It's more polite if you do have the space in the OSCE that you move around them yourself. So having a look from the beginning, having a look at scars, quadriceps wasting, skin changes like rashes, and then any swellings in the popliteal fossa like a Baker's cyst or a popliteal aneurysm. Quite commonly in the exam they probably will have a scar as well because they probably will have a knee replacement. So having a look from either side, I'm not going to demonstrate that. And then if you observe their walking, so we don't have enough space, but if you just get them to walk to the end of the station and then walk back, looking for any antalgic gait, any limp, and looking for any valgus or varus deformity. Thank you, Eloise. If you want to sit back down for me. Get them at 45 degrees, get them comfortable, and then you're looking onto your look and your feel at the same time. So having a feel, you first assess for temperature, using both hands and using the back of your hands. Having a feel all around, the patella will feel cooler than the rest of the knee anyway, that's normal. See if it's a hot joint at all. Then the other feel, you're having a feel all the way around the patella and the tibial tuberosity. Whilst you're doing this, you do it first where they're flat. Make sure you're using both thumbs at the same time and having a look at their face as well to see if they're in any pain. And making sure you feel around the tibial tuberosity as well. And then taking the weight of their leg gently, if you just feel in the back of the popliteal fossa for any swellings. If it's pulsatile, then it's more likely to be a popliteal aneurysm than a Baker's cyst. The next part of feel is you do the same, but you are going to put your knee, put your heel just to here for me, and feeling the same again, whilst your knee is at 90 degrees. Again, making sure you look at their face and feeling the tibial tuberosity and feeling all the bones around there. And again, feeling the back of the popliteal fossa. Lovely, if you relax your leg down for me. Obviously in the OSCE do both legs unless you're told otherwise. They might just say, just do the left leg. The last part of feel will be having a feel for any effusion. So the first one you can do is the patella tap, which is for a large effusion. We'll go from this side. So running your hand down the leg like this, taking the fluid into the patella, and then you might feel an effusion like that. Or if it's a smaller effusion, a more sensitive test is what we call a sweep. So if you take one of your hands up the medial side, pushing the fluid into the top compartment here, and then your other hand taking the fluid down the lateral compartment. If there is an effusion, you'll see a small wave in the medial part of their patella. It's a lot easier to look at on Geeky Medics because it's got a bird's eye view, so maybe just have a look at that as well. Lovely, so that's all of feel. So if I get you to do some movements, so Eloise, if you could take your heel for me as close to your hip as possible. That's fine, and all the way back down. And get them to do the same on the other side. And then you'll be doing the same but doing passively. It's better to get them holding their ankle like this rather than the joint or the heel, just to take the support better. And if you get them to just bring your heel again back over here, and I'll do it, let me take the weight of your leg. And at the same time holding their patella, holding over their knee to feel for any crepitus. Lovely, and same on the other side. So that's your look, feel, move, and then your special tests are for all of your ligaments. So the first one, it's better to start off with the posterior sag, because if you do get a positive posterior sag, you would also get a positively false anterior draw. So if you get them to take their legs at 90 degrees again, so if you put your heel for me to here, that's it, and same again on this leg. You're having a look at how the tibia lies back on the femur. So if it's a straight line, then there's no problems. But if the tibia is lying sagging back on the femur, then that could indicate a posterior ligament damage. Thank you. And then whilst they're up in this position, you can do anterior draw. So you can relax this leg back down for me. You're having both thumbs on the tibial tuberosity here, and you're putting, it's useful to stabilise the leg joint, the leg with your elbows like this, holding it and bringing it forward like this. Any laxity indicates an anterior ligament damage. Lovely, you can relax it back down for me. To do the collateral ligaments, you want to have the leg at 20 to 30 degrees. So if you pop your leg like this for me, Louise. Placing your hand underneath the calf like this. For testing the medial, you press on the lateral aspect, and then on the medial aspect for the lateral ligament. Again, also checking their face as well to see if they're in any pain, because if they do have ligament damage, the chances are it will be hurting them. The other tests that you can do are Lachman's and McMurray's. Each uni is different, so you might want to check with your university which ones they're going to require you to do. Some of them are just an orthopaedic preference, really. So Lachman's is essentially the same as an anterior draw, testing for the anterior ligament, but it's more sensitive. So if you get the leg at 20 degrees for me, and you're doing the same thing, but you're holding the femur with one hand and the calf with the other, and again just pulling it forward with your thumb on the tibial tuberosity. Again, any anterior laxity indicates the deformity. And then McMurray's is for a meniscal tear. So if you get the patient to bring their heel all the way to the hip for me, thank you. If you take the bottom of their leg with your hand, bring it slightly out laterally to test the lateral meniscus, and bringing it all the way down. And any pain indicates a meniscal tear. And then if you do the same again, but bring it up for me. Same on the other side, but pushing it medially. And having it look down. Perfect, thank you. And any pain when I was doing any of those, it's lovely. So that completes the knee examination. You want to present your findings, but at the end of the station, before your time runs out, you're going to want to say, I'd like to examine the ipsilateral hip and the ankle joint, and I'll do a full neurovascular examination of the knee. Lovely, thank you.